Good afternoon, ladies and gentlemen, members of the committee. My name is Dr. Gerrit Noordegraaf. I'm an anesthesiologist in the Elizabeth II Cities Hospital in Tilburg, the Netherlands. I'm also the principal investigator of Working Party 4, in which we used real-time locating systems with a focus on the care of stroke patients, focused on hyperacute care pathways. I'd like to report that we've been very successful in implementing the project, in maintaining the project, and in researching its outcomes, despite the hinder that COVID brought with it for emergency departments. We have enrolled more than 700 patients, of which more than 100 patients were tagged, followed using the RTLS system, and were treated for their ischemic stroke, either with IVT or with IAT therapy. We have found that the use of the locating system needs context information, and we've been very diligent in using data from the EMR to generate that context information for us. As far as outcomes go, we have been successful in finding relevant differences between the data generated by the real-time locating system and the data which has been recovered from the EMR. And this is an important step, as it makes a relevant difference in the clinical quality parameters in this time-sensitive workflow. We have found room for relevant clinical improvements and have implemented this so that we have a before and an after database. We have changed the anesthesia workflow as a participant in the intra-arterial thrombolysis patients. We have also changed the workflow for the patients who receive intravenous thrombolysis in the setting of the emergency department. And we can show that knowing how this time flow goes can make an important difference in time is brain. We have found that despite a high acceptability of wearing badges by staff, both doctors and nurses, there is some resistance. And as part of our query to generalize the use of this technology within the emergency setting, we will have to deal with discussions as wearing the badges on an anonymous basis cannot be part of a generalization program. We are happy to have participated, and we expect to generate some very interesting outcomes and have even set up a PhD program to make this generally available. Thank you for your attention.
The pilot number 10 of BigMedilytics is devoted in one scenario of such emergency department. Emergency department of a hospital is one area when a disease attended precise rapid processing. But if one disease needed this rapid processing is sepsis. Sepsis is a frequent disease that is produced by infections and is one disease that have time-dependent outcomes. In our emergency department of our hospital, we try to identify what is the attention of this patient with sepsis. For this, we get information from the electronic medical records of the hospitals, but with this information, we are not able to identify where will be the bottlenecks that produce delays in the attention of the patients. We also analyze what are the impact of these delays. In the pilot, what we introduce is one RTLS system that is able to monitor in real time and in continuous manner where the patient is and what are the actions that are taken to the patients. We apply this to all the patients with sepsis that arrive to the hospital. And then we analyze this and we are able to detect where are the bottlenecks. Once we detect where are the bottlenecks, this information has been transferred to the staff of the area in order that they can modify some of the attitudes and some of the processes that develop the delays in the attention of the sepsis. With this, we are able to reduce morbidity, we are able to reduce the risk to need critical care units, and we are also able to reduce the mortality in these patients with sepsis. Then the RTLS system, introduce it and place it in the area of emergency room. It is a very nice tool that provides relevant information for a practical change in the processes of attending the diseases that requires a time-dependent manners in terms to reduce outcomes.
The problem that our pilot tries to tackle is bifold. So on the one hand side is doctors and nurses spending their valuable time searching for assets or mobile medical devices instead of being able to care for patients, which is a waste made worse by the fact that there's currently a shortage of staff. And also searching for assets leads to frustration, which might impact the quality of care in a negative way. On the other hand, these costly assets are inefficiently used in the hospital because they are scattered all over the place and no one knows their exact location and sometimes not even the quantity. So in this pilot we combine the problem of the search time with the location of the assets, and one solution is a real-time location system, or RTLS. We implemented RTLS in our mother and childcare department because it's a large department that has many mobile assets, it's a contained environment, and it has closed rooms, so you can't see from the outside what's going on inside. Over 200 assets across 24 groups were equipped with a tag that transmits its location using over 80 patient rooms. We created a software tool where users can find their assets also using a visualization of the hospital. We created a big data analytics tool, and we created monthly and daily management reports to identify improvements both on utilization and on search time. The technical implementation of our pilot was successful with a stable and reliable system, months of data, and room level accuracy. However, the user adoption of our technical innovation had some room for improvement, which leads me to our three key findings. The first one is that there should always be a clear need from one of the end users for your technical solution, otherwise it won't work. The second finding is that there should always be continuous training and awareness being made of the innovation, otherwise people will forget it exists. And the third and final reason is that hospitals are a dynamic environment. Never underestimate the dynamic and go with the flow. Good luck.
While the number of scans that a radiologist is responsible for interpreting every day is very much on the rise, the number of radiologists themselves is either holding steady or maybe even decreasing in certain areas. So this puts a lot of pressure on radiologists to work very quickly. And for particularly difficult cases, they usually need to undergo a certain research process to help them with their decision making. So that may mean consulting various text or internet-based resources, or even waiting to speak to another radiologist. And this process is very time-consuming, and they just simply don't have that time. So the BigMedilytics radiology workflows pilot took a look at a 3D image-based search engine powered by deep learning that provides additional information to the radiologist when they need to interpret one of these scans. That includes information like statistics, reference patients, as well as medical literature, providing them way more information at their fingertips than ever before, and thus allowing them to speed up that research process. Contextual already had a working prototype for visual similarity search in radiology images as a result of an EU research project named Crashmoy. BigMedilytics enabled us to implement this technology into picture archiving communication systems, the main tool of radiologists working in clinical routine. So it's really allowed us to take very large amounts of imaging data and implement it into clinical workflow. So BigMedilytics, we can say, allowed us to take this working prototype and really make it effective and functional for radiologists working in clinical routine. In addition to implementing the search system into clinical routine, the most valuable output of the BigMedilytics radiology workflows pilot was our clinical study, where 8 radiologists read 108 lung CT scans, and it was their task to determine what disease was present. Now, half of the scans were read with the availability of the search system present and half without. And what we saw was when contextual search system was available for use, there was an overall decrease in reading time of 31%, as well as a trend towards better diagnostic accuracy. So this pilot really proves the value of having clinical decision support AI in medical routine, allowing radiologists to become more efficient and read more scans in less time.